Good morning, everyone. My name is Janka Kovács, and I would like to present my PhD topic, which is about life-changing treatments in central nervous system diseases. I work at the Pediatric Center, Semmelweis University. My supervisor is Miklós Garami, and my SMSs are Vanda Máté and Mahmoud Obeidat. My vision is to improve the life quality and extend the life expectancy of children treated with brain cancer, and I would like to provide guidelines for these patients. I've got two ongoing projects. The first is about antibiotic-impregnated ventriculoperitoneal shunts, and the second is about oral targeted therapy. My first topic is about antibiotic-impregnated VP shunts for infection prevention. This was a systematic review and a meta-analysis. 1 in 500 to 1 in 1,000 babies are born with hydrocephalus, but there are some other reasons which can lead to this condition, for example, malignancies or hemorrhage. Ventriculoperitoneal shunt is the most common treatment for this condition, and an estimated 30,000 procedures are performed yearly in the United States. Our problem is that the rate of bacterial infection is still really high. It's between 3 and 20%, and it can cause, for example, 2 times higher mortality. That's why our aim was to compare the rate of bacterial VP shunt infection with and without antibiotic prophylaxis. So our population were all the patients, also adults and children. The antibiotic prophylaxis was an antibiotic-impregnated shunt, which was impregnated with vancomycin and rifampicin. And we hypothesized that if we use this antibiotic-impregnated shunt, then the rate of bacterial infections decrease. This was my systematic search. I had like 3 main search key. The first is about the VP shunt, the second about the infection, and the third about prophylaxis and treatment. First, I had more than 10,000 hits, and at the end I had 27 eligible articles. 4 of them were randomized control trials, and the other 23 were observational cohort studies. This is my main and biggest forest plot, which is about infection in a mixed population. All the 27 articles are here. The measure of effect was odds ratio. If the odds ratio is below 1, that means that antibiotic-impregnated shunt has a protective factor against bacterial VP shunt infections. As you can see, the overall odds ratio was 0.44, which means that if you use a standard VP shunt, then your patient will have almost 2.5 times higher chance to get a bacterial VP shunt infection. My second forest plot is also about infections, but here I had 2 subgroups. The first subgroup was about children, and the second about adults. Unfortunately, in the adult group, we only had 4 articles. This forest plot shows us a tendency that in children it could be even more useful to use antibiotic-impregnated VP shunt, because there the overall odds ratio was 0.38. My third forest plot is about shunt failures. It contained 9 articles, and here the overall odds ratio was 0.73. It can be because also peritoneal adhesions and hemorrhage can lead to a shunt failure, not only infection. For example, in Atanello's article, you can see that the odds ratio was 0.34. This could be because here the population were only children, and they had a planned surgery. But in Wong's article, where the odds ratio was 1.27, all the surgeries were urgent surgeries, and the population were adults. And adults had more risk factors like steroid treatment and diabetes, so that's why there are so big differences in the articles. But at the end, because the main reason of the shunt failure is infection, we would like to suggest to use antibiotic-impregnated shunt to also prevent the shunt failures. The strength of my study is that I had a large number of patients, and we had articles from 9 different countries. The limitations are that there were only 4 randomized control trials, and we saw the absence of detailed age grouping in some articles. So the conclusion is that antibiotic impregnated shunt decreases the rate of bacterial infection to about 1/3, and we would suggest to use it everywhere where it's available. But more randomized control trials are needed about the shunt failures, and also they should investigate separately adults and children. The status of my manuscript is that we submitted the revision just yesterday. My target journal is a D1 journal, Journal of Neurosurgery. My second topic is about defining the optimal and personalized dose of oral selumetinib in children treated with plexiform neurofibroma. This is going to be an observational study at our clinic, and we started the project in 2022, November. So neurofibromatosis type 1 is an autosomal dominant condition. It's caused by a pathogenic variant in NF1, which is a tumor suppressor gene. And in these patients, between 5 and 15%, they can have a plexiform neurofibroma, which can cause them extreme pain. Selumetinib is a non-selective MEK inhibitor, which can be used also in this disease, and it's also available at our clinic at the pediatric center. The problem is that currently we don't have enough data about the pharmacokinetics of this MEK inhibitor in children treated with NF1. So basically we give the selumetinib based on the body surface, but a lot of the patients have side effects. For example, nausea, vomiting, abdominal pain. And as far as we don't have accurate data about the pharmacokinetics, when we experience some side effect, we are just splitting the dose. And basically our aim would be to define the optimal dose of oral selumetinib based on the drug level monitoring, so reach an adequate blood concentration without any serious toxicity. We would like to do this clinical trial in all the children treated with NF1, and we would like to measure the exposure and the pharmacokinetic characteristics in the blood. Our main goal is to provide recommendations for optimal selumetinib dose to reach the optimal drug level without toxicity. We would like to include all children under 18 years old who have also plexiform neurofibroma and who are taking oral selumetinib therapy at least since 1 month. We would like to exclude those children who take other oral targeted therapy. We already started our pilot study. We did the measurement for 10 children between 5 and 14 years old. And from these patients, almost 80% had some side effects. You can see that table there that we were taking samples 6 times, and most times we only measured the drug level, and at the beginning we also measured the kidney, liver function, and the blood count. We already have the ethical improvement, and we would like to continue it at least with 10 other patients. So I already finished my first project, and I'm planning to finish my second project at the end of August 2024. Thank you for your attention, and my favorite quote is from Kurt Vonnegut: "Science is magic that works."
Congratulations on your presentation. My question is regarding the first project. About the difference between the adult group and the pediatric group. And the question is, why is more better to use VP shunt among children than in adults? If I remember good, the odds ratio was more significant than in case of adult group.
Yes, thank you for your question. So I think that, as I mentioned at the shunt failure forest plot, children have less risk factors. This could be, and also it's a limitation that we only had 4 articles about the detailed group in adults. So maybe if we have more articles only about the adults, then it would be also more significant. But
the question to the second project, what number of patients do you plan to investigate in this pharmacokinetics study, or do you see a do you want to perform a safety and efficacy trial as well?
Yeah, pharmacokinetics trial. So basically, we are the only center at Hungary who gives salumetinib. So we have all the patients around Hungary who have this plexiform neurofibroma between children. And right now we have, so that is also a limitation that small children cannot take because this is basically a tablet, and we can only give it from 3 years old. And we have now...
This is just because of the formulation, so but the tablet, or here is Kinga, and you can ask her to give a solution.
Yes, we already had a discussion about this with the pharmacists, but they cannot solve it. So basically we have 35 patients right now.
Okay. Do you plan to offer the treatment for all Hungarian infants and kids who suffers in this disease?
Yes.
So, and what is the estimated number of it? All in Hungary?
Right now, so everyone at Hungary knows that we are the center where they can get this oral treatment. They even have a Facebook group for the parents and things like this. So all the patients who have this disease and who have this plexiform neurofibroma are being treated right now at the clinic. So this is the all number in Hungary.
Interesting.
But I don't know who...
So the estimated number is, if there is 80,000 per year newborn babies, then the 2,000 per, so every 2,000 or 3,000, then a minimum of 30 per year, the prevalence of the disease. So up to 18 years of age, there is more than 300 or 400.
Yes, but not everyone have plexiform neurofibroma. As you could see, only 5 and 15% of all the neurofibroma patients. So.
Great. Okay.